who's going to take us through the weekly numbers. And then our colleague Tolu is going to talk through some findings. Before we kick off, I'm going to pass over to Sir David King, who's going to welcome everybody. Sir David.
Welcome to today's Independent Sage press conference. Before I hand over to Professor Pagal, I want to extend a particularly warm welcome to Independent Sage's newest member, Dr. Tolu Oni. Tolu is an urban epidemiologist at the Medical Research Council at Cambridge University, and we think her experience brings a huge amount to the group, so we're very excited to have her on board. For now, let me pass over to Professor Pagal to take us through the week's numbers.
Right, let me just share my screen. Okay, so hi everybody. I'm going to take you through the latest numbers on COVID-19 in the UK. All the data is coming from a combination of the government's daily figures, the Office of National Statistics, Public Health England, and then the government's report on NHS Test and Trace. And these are the main topics we're going to be covering. So looking at the new numbers for deaths, hospital admissions, and new infections, and then spend a little bit of time really digging into the test and trace results, and also what's missing from them. Just because as we're opening up our economy and our lives, a functioning test and trace system is the scaffold on which you can build that. You really need it in place to support the extra risks you're adding. So I wanted to spend a bit of time looking at those results and then just end on a little summary. These are the new UK deaths from COVID-19 in the UK. They were quite high on Tuesday and Wednesday, over 170, but it went down a lot yesterday to 89 deaths recorded. I really hope that continues, because for the last 3 weeks, it's been pretty steady at about 150 deaths a day on weekdays. New hospital admissions have had a slow, continuous decline. We had 145 recorded on the 30th of June, which is the last date data is available, compared to almost 400 a week earlier, so they are dropping. I'm just going to mention that yesterday's data suggests that almost half of new admissions were in Wales. This doesn't match Public Health Wales data, so I'm wondering whether there's a slight error there. So that number might change next week. This is now the number of new UK confirmed cases. So to be a confirmed case, you have to have had a test, and then that test has to have been positive. So you're not capturing people who have COVID but haven't been tested. Again, that's obviously declined a lot from the peak. The rate of decline has notably slowed since the beginning of June, which is when we started opening schools and then shops at around here. It was quite steady between about 800 and 1100 for the last week. Yesterday was 576. So that's quite a lot lower, but the government did update the counting method yesterday to exclude duplicates. So that means the same person being tested more than once has now been excluded. Now that's a good thing. And I'm hoping that by next week, we'll be able to have applied that correction to historical data as well. The government isn't actually currently publishing an updated estimate for R, or at least I couldn't find it anywhere on their website. But I did go and I had a look at the Cambridge Medical Research Council unit, which does the modelling for SAGE. And I also looked at UCL's group led by Professor Friston, which uses a different type of modelling. Both of them agree that R is somewhere between 0.7 and 0.9, depending on where you are in the UK at the moment. So I just wanted to spend now a little time about how you get a test, because after the Leicester outbreak, there's been a lot of discussion about different ways of getting tested and how you become a positive case. So the first type of test is a test done in hospital. So typically if you're a patient that's been admitted with suspected COVID and is processed by Public Health England or NHS laboratories. Now that's called Pillar 1. And up until the end of April, that's pretty much the only type of testing that was available. And the key thing about it is that these are the only tests for which the government was providing detailed data by location about. So for all of these tests, you knew where they were. Now, from the end of April onwards, the government opened up testing to anyone with symptoms. That's called Pillar 2 testing. And that now is the majority of all the tests done in the UK. And this is for everyone else. So that includes care homes, but it also includes you and me if we had symptoms and wanted to get tested. And they're processed by commercial partners, and there was no location data available for these. So that's why if you wanted to look at detailed location stuff, you couldn't really do it using the data. But that is now changing as of this week, I think. Now, the point about these Pillar 2 tests, or tests for everyone else, is that they rely on people with symptoms letting the NHS know and then getting a test. So they kind of rely on self-reporting. So we don't know about people who have COVID but actually don't end up getting a test. So where are the new cases and how many new infections are there? So this is a map for England for last week from Public Health England report. I tried finding maps for the other nations and couldn't find any that were specific to just last week. If anyone knows if they exist, then please let me know. So here you can see it's really variable depending on where you are. This hotspot bang in the middle, that's Leicester. This hotspot is Bradford. And having this kind of information available daily would be really useful for people. Now, as I said, the number of confirmed cases is just people who get tested and then test positive. But how many new infections are there? How many actual people are getting COVID every week? The best estimates are somewhere between 20,000 and 25,000 a week. So that's between 3,300 and 3,500 a day. Those estimates are England only. And they come from the Office of National Statistics' latest report that came out yesterday, and also the Cambridge Epidemiological Model. And both of them are very close in agreement, saying they're between 20 and 25,000. For the second week in a row, the Office of National Statistics says that the numbers of new infections have stopped falling. And I think that's quite significant, because this is the one survey out there that doesn't rely on people self-reporting. It doesn't rely on anyone coming forward. They go out and they actually just test a whole load of people, regardless of whether they have symptoms. So given this, how is NHS Test and Trace working? The report that came out yesterday has this kind of helpful flowchart in it of how the system works. And what I really put this up for is that they concentrate on testing. So this is Pillar 1, tests in hospital. This is Pillar 2, everyone else. You get a positive test, you get transferred to the contact tracing, which splits into 2, where you have non-complex cases, which is kind of online and call center stuff organized centrally, and then complex cases, which is like if someone in a hospital or care home gets infected with lots of contacts, that goes to a local public health team. And they concentrate on that, but what they're missing is the finding. So for a system to work, you need to be able to find as many new people with COVID as you can. And then once you've reached people's contacts, you actually need them to isolate. It's the isolating of contacts that makes contact tracing work. And isolating is difficult, and many people will require support to do it properly. And just looking at the finding, I was a bit worried about this kind of fact that we're relying on all this self-reporting of people with COVID to get tested. So I went to the government's main website on COVID and the nation's main websites on COVID and just had a look and say, what are the main bullet points you see when you hit their website? So this is the Department of Health. It doesn't mention testing or contact tracing at all. It gives you some basic public health messages. And all it says is, do not leave home if you or anyone in your household has symptoms. Wales says the same. Again, there's no mention of testing or contact tracing. It just says stay at home if you have symptoms, but it does helpfully give you some of the symptoms of COVID. Scotland, however, does encourage people to get a test. At the bottom here, you can see it says self-isolate if you have symptoms and book a test. What it doesn't do is tell you why you should be getting tested, and it doesn't mention contact tracing, because the importance is that you're doing it to protect others. In Northern Ireland, they simply say, if you have symptoms, you can get tested. But again, it doesn't tell you why you should get tested and anything about contact tracing. And the reason I wanted to highlight this is that as we're opening up and wanting to restart our economy, and we're relying on a test and trace system to protect us, we need to find the cases. And I'm just worried that people don't know that's what they should be doing. So given that, how did NHS test, trace and isolate do over the last 4 weeks? And I'm looking at it all together because actually there's not been much change week on week. I've estimated the number of newly infected people from Office of National Statistics, and then from that, the number of newly infected people with symptoms, because that's who we're targeting. We're only targeting people who have symptoms for testing. So we should be finding all of these people. So this is kind of the find and test. So we want to find them, test them, have them test positive. They get then referred to contact tracing. And all of these numbers come from the test and trace report. Once you've been referred, you have to then be reached. So a contact tracer will try and reach the person with symptoms who's just been confirmed positive. And then they ask them about how many contacts they've had. And then they try and contact their contacts and ask them to isolate. And over the last 4 weeks, if you're starting from everybody who's got symptoms who you're trying to reach, only about a third of them ended up providing at least one contact. So we're not reaching nearly enough of them. And then of the people who we do get contacts for, do those contacts actually isolate? So remember that I was saying how there are two kind of main ways of doing contact tracing. There's the complex cases with local public health teams, and they typically have lots of contacts per person infected. And then the non-complex cases, which is people like you and me, which go through a central system, which is kind of online and call centres. And what you can see is that the local public health teams had way more contacts identified. You'd expect that. And they're reaching almost all of them, 99% of them they're reaching. The central system, however, is only reaching about half of the contacts that they've identified. Now, that's partly just because of their nature. In these kind of complex cases, you know who's working in a hospital. It's easier for you to get in touch with them. But as this is becoming the main way of doing contact tracing, and that has happened over the last few weeks, it really matters that we're only reaching about half of people who are identified. And the other thing that the test and trace report had in it this week that didn't have last week was timing of test results, how quickly people are getting them, only for one type of test. And then they have timings for how quickly contacts get reached, but only for some types, only for this central system. And it looks from that less than half of contacts are being reached within 3 days of that index person getting tested. And we really need to make that much higher. You have to ask people to isolate as soon as you can, because you're most infectious just before you get symptoms of COVID. And then we have no data on how many contacts are actually isolating. And we have no data on whether they're doing it properly. And we have no data on how many of those contacts go on to develop symptoms or whether they get tested. So we actually don't know how well test and trace is doing at all. So just to summarize, we are seeing kind of declines, even though quite small declines in positive confirmed cases, but we don't know if that's because fewer people are getting tested or because fewer people have COVID or some kind of combination of both of those things. But the Office of National Statistics, which doesn't rely on self-reporting, does continue to say that the second week in a row that decline in cases has stopped. So they're not seeing any more reduction. So I'm kind of inclined to think that we have leveled off in the UK. None of the nations mentioned contact tracing as a key part of COVID response on their main web pages, and only Scotland actually actively encourages people to get tested. And added to that, we know that the system is not reaching enough newly symptomatic people with COVID, and that fewer than half of contacts are reached within 3 days of a person being tested. But this is from quite patchy data. It's definitely not the whole picture. So that's just an estimate. and that the crucial data on how many contacts are actually isolating or go on to develop symptoms is just not available. So that is kind of the summary of what the data are telling us. And I'm just going to end with this, just saying, the pandemic isn't over. We still have more cases than similarly sized European countries. And then we have the USA as a reminder of things can get quite badly out of control quite quickly. Thank you.
Thank you, Professor Pargle, for that really informative presentation. We're now going to pass over to Professor Oni, who I think is going to add some insight to that. Professor Oni, are you ready?
Yes, thanks, Zach. I'm just going to pick up on the points that Christina's made by making 3 points. So going to illustrate the importance of what has just been described, of the importance of the data, particularly missing data, illustrating this with Leicester, firstly. And then I'm going to talk a little bit about what happens from tomorrow when the restrictions are being eased somewhat. And then lastly, touch a little bit on beyond that, thinking more long term. So firstly, we think about Leicester. By now, we're all aware of the outbreak, and this is really an illustration of why the data, particularly the missing data around finding the cases, is so important. As Christina mentioned, we just simply need to know where the new cases are, and we need to be ensuring that the contacts are isolating. Now, we've examined the issues at play here in Leicester, and a failure to respond to the increase in infections in Leicester at an early stage before they reach these crisis levels is what we're seeing playing out at the moment, because we didn't have a sufficiently early enough intervention to break the transmission cycles. Just to reiterate a point that Christina made, that you're most infectious just before you get symptoms. So why would this not have been done in the case of Leicester? Well, there are two issues that we've identified as barriers to that. Firstly, the fragmentation of the testing system, as was previously highlighted, meant it's difficult to ascertain in new cases, particularly because we know that a lot of those, almost 80% or over 80% of the new cases came from that pillar 2 from the community testing, which until recently didn't have local data available. And secondly, importantly, the local unavailability of data. So with those two different sources of data, and with a overwhelming majority of new cases missing at the missing data at the local level, it really is a significant impediment to early intervention and picking up. Because otherwise, when you look at the graph, what you see is the pillar 1, you think the cases are going down. So that really is a tale of caution. So as we go into tomorrow, where we know that the restrictions are being eased even further, whilst hopefully this doesn't happen, but we fully expect there to be further local spikes. And it's really important at this stage to state that we can avoid a situation where additional local lockdowns are needed. And I think we can all agree, given the strain that's being placed on individuals and businesses today, that this is something that is worth putting in an extra effort to avoid. But avoiding these additional local restrictions will require strong prevention and control strategies to avoid being blindsided by what we could consider a predictable, preventable surprise of local spikes. So there are 3 key things really when we think about preventing the transmission, because ultimately control hinges on that early identification and a coordinated strategy for intervention, for identifying and tracking contacts and ensuring they're isolating. So the first is a really strong test and trace program that includes active case finding, but also data and being able to track what proportion of the contacts being advised to isolate are actually isolating, and what support, ensuring the support available necessary for isolation is made available. The second is that's critical. It's an early local response. ensuring that the local authorities have the real-time access to that local data, preferably at the postcode level, from both testing streams with sufficient granularity to affect that early local response. And that includes the test and trace data at the postcode level, but as I mentioned, also the active finding and the isolations to support data, which Professor Pargar highlighted earlier as currently missing. The third, obviously, is the individual measures. So, we mustn't forget the happy birthday twice, hand hygiene, that still plays a role, face hygiene, avoiding crowded places, etc. But importantly, seeking testing as soon as possible if you have symptoms, because it's really important to break that transmission cycle, because to identify the contact early. But this will require efforts working with the communities to inform a contextualized public information campaign on the symptoms, on physical distancing measures, etc. So that where local restrictions are necessary, these are not just seen as a means of isolating whole populations and waiting out the transmission, but as a measure instead to mobilize the resources needed to ensure and strengthen that find, test, trace, isolate system, so in order to ensure that the transmission cycles are broken. And lastly, ultimately, beyond Leicester and beyond tomorrow, we need to start thinking out, and we need to have articulated a clear strategy to fully control and eliminate the virus. And so beyond waiting for a vaccine magic bullet, which in any case strategy to avert these avoidable deaths. And we've seen examples in different settings of how possible this is. But just to reiterate that this will require locally led find, test, trace, isolate, and support systems with that required local data. It will require well-designed and scientifically based plans to act quickly to identify early increases in the cases and suppress spikes, fully engaging development of these. This should also incorporate specific criteria for how we define when those additional would end, and fundamentally a public information campaign to really stress that things are not back to normal. And as much as we want to move on and get things going, I think we believe the quickest way of doing this is to ensure that these systems and these measures are put into place and strengthened at the local level.
Thank you, Professor Oni, for that insight. Really interesting. We've got, as ever, through the week, lots of interest from the public and lots of questions to get through, as well as the journalists that we have here. Just before I do that, can I a further reminder that if you're within the Zoom call, please keep an eye on your chat function and look out for my colleague Andrea, who will be sending you a message. So now I'd like to pass to John Hillier, if you're there. John from Forest Hill, are you with us?
Hello, yes. Yeah, can you, all good. Great, yes. Thanks for letting me ask a question. Obviously, you've touched on the lifting of some of the restrictions tomorrow. And as part of that, we're all told that we can go for a haircut. Some of us have inflicted some damage to our hair already, self-inflicted, but there's lots of people who are eager to go for a haircut. My grandpa is 92. He has been self-isolating alone for months. With the exception of lifelong asthma, he is fit, he's active, and he's really clued up about everything that's going on, but he is considering a trip to the barbers. Risk-free decision, especially now. I also know that with that in mind, the best we can do is try and make an informed decision, especially since the challenge we all face as responsibility shifts back to individuals is to try and make sense of what is right for us. as far as I can tell, he's in an area, according to some of the data we saw, where cases are quite low, but I'm still worried about that decision. And a lot of the lifting of restrictions seems to be being treated all one size fits all lift. So I wonder if you have advice or thoughts about people like my grandpa who are high risk, and whether a trip to the barbers could be considered fairly safe or actually quite a risky luxury.
Question, John. I think I might start with one of the behavioural experts. I'll pass over to Professor Mickey first.
Hello, thank you for that question. It's very pertinent to the current situation. And I think what people need to do is to really have a risk assessment and risk management strategy. So if your grandfather does go to the barber, he should ensure that he washes his hands before and immediately after, or sanitizes his hands leaving. He should ensure as much as possible keeping distance and trying not to be face to face. He should ensure that the barber wears a face mask, and really importantly, he should really concentrate on not touching his face, his nose, or his mouth, his nose, or his eyes, because that's how the virus gets into the body. So if he is going to do that, these are things that can be done. He can also ask to sit beside an open door. We know that when you look at the people who spread to at least 5 others and look at the transmission instances, 97% of those being indoors and 3% outdoors. So ventilation can make a big difference. Everybody needs to judge for themselves what's going to be acceptable risk, but anything you do which is in contact with other people, especially indoors, is going to increase the risk of transmission. And some situations are going to be much more risky than others. In a barber's or a hairdresser's, it's slightly more controlled. I think the big concern is going to be in pubs for 2 reasons. One is, I think there are likely to be more people and less control. I don't know whose responsibility it is going to be to try and maintain the social distances. But also we know that alcohol is a great disinhibitor of behaviour. So even if people go with all the plans that I've outlined, after a couple of drinks, the chances are that those plans will have been forgotten. So I would suggest, firstly, people maybe want to you go limiting your own drinking to 1 or 2, so at least you can try and keep yourself safe as well as possible.
Thank you, Professor Mickey.
Thank you very much, Zach. I mean, when we're making decisions about whether we go out or not, there's a number of things to consider. One is the risk that is going to be posed outside and the risk that personally that we have. And Susan's already gone through all the risks assessments that you need to do outside. In terms of the personal risk, what we know about coronavirus and COVID-19 is that there are certain things for definite that puts you at high risk. Age. If you're elderly, you're 10 times increased risk. If you have comorbidities and your grandfather has asthma, if you're from a deprived area, if from a Black minority ethnic health area, and males. So he's already has 3 risk factors there: age, comorbidity, and being male. And then this is a decision you need to make. Is it really important to go out there and have a haircut or whatever else that you're going to do? And that's the balance that the individual needs to take. If there are other alternatives, I would go for the other alternatives.
Thank you, Professor Kunti. So David, did you want to come in before we pass to the next question?
Just very quickly to say I'm in that bracket as well, as an older guy, and I am an asthmatic as well. I don't plan to go for a haircut. I haven't had one now for 3.5, 4 months, and I don't plan to go for one. I think for me, the risk is just too much.
And you look great.
John, I was brought up in Forest Hill, and I can strongly recommend Maison Charles in Perry Hill.
Okay.
If it's still open. 50 years ago.
I'll look it up. Thank you.
Thanks for the question, John. Can I invite David Shookman from the BBC, if you're there, David?
Let's do that. Is that helpful? Can you hear me now?
Yeah, we can indeed.
Yeah, thank you. Pubs reopening has been mentioned. What about the great holiday flight rush? What do the various experts think about where the risks might lie? Is it being crowded at airports, on the flight itself, the other end? Do you expect to see a spike as a result? Thanks.
Professor Costello, would you like to come in first on that one?
Well, you know, the number of people you meet, how often you meet, how close you sit in an enclosed space. So obviously being in an airport, being in a plane, and being in hotels or wherever you're staying abroad all slightly increase your risk. Having said that, we've got the highest rates in Europe. So assuming you're flying to Europe, the risk where you're going to be is going to be slightly less. I hear, I don't know if anyone else has thoughts about aviation, because I understand, but I don't know the science behind it, that the way air circulates in aeroplanes is favorable to extracting viruses, or is that just optimistic sales pitch from aircraft? Does anyone know?
Professor McGee, I think you might want to come in on this one.
Yeah, well, my understanding is that as well. There is quite a high level of circulation, particularly in some of the newer planes. So, but clearly you are going to be sitting very close to a lot of people, particularly with load factors the way they are. So although the technology should help, you still have a risk.
And Professor Scally.
There's quite a detailed document prepared by the European Centre for Disease Prevention and Control, along with the airline industry, which deals with a lot of the issues about the actual movement inside the metal tube, so to speak. And that may or may not be satisfactory. I find it still, it's a bit too closeted together for my liking, but that agreement is in place. But that's not the point, really. It's not the within flight issue. It's not the only one that counts. It is the passage through all of the transport systems people may use to get to and from airports. But I think more importantly, as Europe loosens up and people do go for their Mediterranean holiday, I really worry about some of the places they're going on holiday becoming really melting pots for the virus, as people fly in from all sorts of different places and enjoy themselves, and alcohol will undoubtedly feature. So I wouldn't at all be surprised if over the next month or two we did see some really big flare-ups in some holiday destinations. Now, the problem that people have is, of course, it will be very difficult for them to get health insurance. It may be very difficult for them to get insurance that will protect them from the possibility of being locked down in a particular destination that they're going to. And it may be possible that if there is a flare-up, people may not be allowed to return from there, or if they are returned, they may be put into compulsory quarantine. So my personal feeling is that we should this year forego foreign holidays. And if we really want to make a contribution to getting the UK economy and the Irish economy, UK and Ireland as one common travel area, back on its feet, one of the best things we could do would be to spend our pounds and our euros in the UK and in Ireland and not be exporting money elsewhere, support the domestic tourist industry and keep jobs alive in the country.
Thank you, Professor Scally. And before we move on, there's a question coming from Twitter that I think is particularly pertinent, that relates to the Prime Minister's father. What is it irresponsible of Stanley Johnson to have flown to his Greek home at this time? Does anyone want to comment on that specifically? Professor Pillai, would you like to comment?
Well, I pity the Greek island, to be honest. Greece has done incredibly well at controlling the epidemic. It's one of the countries perhaps Greece and Vietnam that have been the most successful, even though the infrastructure we have understood has been weak. And of course, there remains the quarantine for UK visitors to Greece, quite rightly, because of the higher infection rate here. My understanding is Stanley Johnson is going to make sure that his property is COVID-free. That's what I heard. But I think we've got to be respectful of those countries that have made huge efforts and have been more successful in controlling their pandemic than we have.
Thank you, Professor Pillai. And maybe one more from Professor Riker before we move on.
Well, even in the Johnson family, I think we can allow that, the Prime Minister is not his father's keeper, and I'm not sure he can control his behaviours. Nonetheless, the issue of trust is particularly important. And in fact, the evidence shows that in some ways, trust is more important to compliance at this stage than under lockdown. So the figures show that erosion of trust undermines people's willingness to use the find, test, trace, isolate and support system, and in particular to give information about themselves to the authorities. And one of the best ways of undermining trust is the notion that there's one law for them and one law for us. It divides us from the authorities and turns them into them. And there's no doubt that this affects that perception in exactly the same way that the Cummings affair did, and therefore at the very best it's not helpful. We need to rebuild trust, and in such a volatile situation I think everybody's got responsibilities to make sure they don't undermine trust.
Thank you, Professor Riker, for that. I'd like to pass over to Hazel Fernandez from Leicester. Hazel, if you're with us.
Hello everybody, this is Hazel. I'm calling from Leicester. And I'm just speaking on behalf of people with underlying health conditions. COVID-19 has put a whole new spin on people with weak immune systems and respiratory infections like asthma and diabetes. Now, people who have been shielding since the 1st of March or in March, that means they cannot leave their house and not have face-to-face contact. In some cases, the people they live with, they have to live separately from them. So from the 1st of August, shielding is going to be paused. And a lot of people who can't work from home, for instance, teachers, paramedics, people who work in retail are very nervous because they've got to make this big leap from shielding to go out into the workplace. So I just wanted to ask the panel to find a COVID-safe work environment. What procedures should workplaces put in place for shielders? And are GPs being involved in the risk? And what's the safest course of action for someone who's shielding?
Professor Kunti, would you like to come in first on that one?
Yeah, hi, Hazel. Great
Hello.
question. We're all worried about the issue about shielding as well, and the people coming out on the 1st of August. Again, the recommendation is if you can work from home, then please work from home. There is going to be new guidance potentially coming regarding the shielding risk factors, because initially when this virus came in, we thought it was similar to the influenza virus, and it was going to be people with COPD and asthma, so chronic respiratory diseases, who were going to be affected. But we've seen, as you've mentioned, that the people who've been affected are more likely to be people who have cardiovascular disease, hypertension, and diabetes. And this is a large number of patients. So I think we need to watch this space. If they can work from home, they should continue working from home. If they need to get into work, then all the measures that we've already discussed, first of all, the environment needs to be safe to reduce the risk of transmission. This includes hygiene within the environment, making sure the ventilation is there, and making sure the personnel, the individual person, has had an individual risk assessment done. And there are a number of risk assessment tools out there. If that risk is high, then that person shouldn't really be going to work. And if the risk is low, then they should have all the protective equipment that's required. And in terms of primary care, at the moment, primary care hasn't got the proper guidance to say what should we be doing. We're just told that this is the list of patients who are shielding, and we have that list updated on a regular basis, but there isn't any additional guidance to that. except for what everyone else knows.
Kamlesh, where would Hazel get a risk assessment tool from in Leicester? Would that be from the Public Health Department or?
No, so we've developed one for the NHS staff. That's on the NHS website, NHS England website. As you know, when we did the school report, we developed one for the school report as well. There's one on our independent stage for the schools. But the principles are very, very similar. It's looking at the environment and looking at the individual. And as I mentioned, the individual risk factors that we really know of and we've got good quality evidence is the age, comorbidities, whether people in deprived areas, BME populations, and the male.
I wonder if I can pass over to Professor Mickey on this one as well.
Yeah, I do think there's a question about where this responsibility lies for a safe working environment. And it should not be up to the people, the vulnerable people who've been shielding to ensure that their workplace is safe. It really does need to be the employer's responsibility. And there are various bodies, there are health and safety representatives, there are trade unions, there's other staff associations that've got the expertise to really look at the safety in the workplace. The other thing to mention is that as Independent Sage, we have produced a report on this very issue of shielding, and it's on our website, as that can confirm whether it's on our website, certainly will be today, where you can get more information about these really important issues.
Absolutely. Thank you for the question, Hazel.
Thank you.
Can I pass to Ian Sample if he's with us? Ian from The Guardian, are you there?
I am. Can you hear me okay?
We can indeed.
Okay, wonderful. Thank you for taking my question. I wondered if one or two of the panel could sum up the impact that these missing data will have on our ability to keep on top of the virus. And as a follow-up, we heard talk fairly recently about the virus being in retreat. I'd like to ask the panel to comment on that statement, whether that appears to be true. Thank you.
Thank you for the question, Ian. I wonder if we could go to Professor Pargle, and then perhaps I can bring in Professor Pollock as well on the data. Professor Pargle first.
Sure. I mean, in terms of missing data, it just means that we just don't know how well we're doing. So, you know, in terms of saying the virus is on retreat, I don't think we can say that. The Office of National Statistics survey has about 30,000 people that it tests every 2 weeks, which I think is pretty definitive. It's still not that many people, but they're saying it's not on retreat anymore. We still have more cases than the rest of Europe. We started off with 0 in February and then got to where we were in March. So I don't feel happy saying the virus is on retreat. We're better than we were, for sure. But to kind of think that we don't have to be cautious, I think is false.
Thank you, Professor Pargle. Professor Pollock, would you like to add to that?
Yes, I think this is a very important issue. And as Professor Pargle has highlighted, there's been a real issue with the Pillar 2 commercial labs, and that we still don't know how many people were actually tested. And that's quite extraordinary because we do have very good data for the NHS, and we'll never know how many people were tested. They've now spent a month trying to find out how many people were actually tested positive. So at long last, we have some of these data. But as you can see, the Pillar 2 data tests are being by the commercial labs are mainly being done in the community. And that's where we have the least amount of data. And that's been the case all along since the start of this epidemic. And that's partly because the notification system wasn't being followed, so we weren't getting the suspected cases. And then the cases in the community were not actually being tested, and the criteria kept changing over the last 3 or 4 months. So this is really where we're very weak, and it's where it's essential that we get really good data on the community, because that's how we get on top of the outbreaks. The second point is that we haven't had good data coming back to the directors of public health who've been tearing their hair out. And you can't get on top of the outbreaks without really good disaggregated data with the 7-digit postcodes and occupation. I think the last point I'd like to make is, as Professor Pargle elegantly presented today, the contact tracing system, the test and trace, is still not working effectively. The public health outbreak teams are doing a very good job. If you only manage to get contacts from just over half of your cases, you know you've got really serious problems, especially as we come out of lockdown. It's going to be even more imperative to capture all those cases and for people to feel enough trust in the system to come forward. I hope that's answered your question.
Thank you, Professor Pollock. I wonder if I could pass to, I wonder if Professor Friston has anything to add here in terms of a possible spike.
Yeah, I mean, it's a very important question, which we started off with, really, the nature, accessibility, and the use of the data. I think it might be useful just to sort of distinguish between data that's useful for informing things like the prevalence of infection or the reproduction ratio, for the modeling and understanding whether we are in the tail of the epidemic, and data that is used locally to respond and optimize those responses at a local authority level. So I think there are two very different uses of data here. One is to flag up where we need to prioritize and enrich testing facilities, for example, and accelerate FTTI and containment programs on the one hand, and I think that's largely what we've been talking about. From the point of view of the modeling, the granularity actually is not an issue. So you actually need the aggregated data to take out the sort of the randomness to get a clearer picture, but this is a coarse-grained, fuzzy picture of what's going on. So under the qualification that this is a coarse-grained, fuzzy picture of us as a collection of regions or a nation, I think it would be fair to say that the virus is in retreat, but it's a very, very slow retreat. And that slowness is indexed by things like the reproduction ratio. The big question is whether that retreat will, over the next few months, turn into a second wave. So from the sort of population dynamics perspective, things are getting better aggregated. From your point of view, if you're living in Leicester, it won't look like that, but when you average all Leicesters across the entire country, then things are getting better. The big issue is a slower dynamic that may confront us around Christmas, and it's that slower time course, that fuzzy, coarse-grained picture, for which the aggregate data becomes incredibly essential. And as Alison was just saying, we really do need to know the pillar 2 total amount of tests in order to interpret the prevalence of infection that's driving those positive test cases.
Thank you, Professor Friston. This is obviously a really pertinent issue, and lots of the panel want to comment here. Can I pass to Dr. Hack to talk briefly on this?
Thank you, Zach. I think the other issue, of course, is that the combination of the missing data, the missing pillar 2 data that wasn't shared with Leicester early, the fragmentation of the testing system, the poor communication between the centralized system and local officials should actually ring alarm bells for us for all the other Leicesters, if you like, that exist in this country. Leicester could arguably be the first one, and arguably what we don't want is to be hitting crisis in every city where we react, where the government has to react with the harsh and blunt measure of a lockdown. I mean, lockdown in Leicester has been devastating, absolutely devastating for local businesses, which have been struggling throughout this pandemic, and that's across the country. And in an ideal situation, you don't want that. In an ideal situation, you want a strong FTTIS system, a test and tracing and isolate system, a strong system of communication, and a strong system of locally based test and tracing. So that's very important to consider as well.
Thank you, Dr. Hack. I'd like to go to Professor Riker for one final comment on this before we move on to the next question, if that's okay.
In the end, the whole point of the system is to get people to isolate. However much you test people, however many contacts you get, if people don't actually isolate, the system achieves nothing for you. And I think that others have pointed out the many other very significant holes. I want to point to the critical nature of the fact that the only figures we have are the numbers of people who've been asked to isolate, not the numbers of people who have actually isolated. And what's significant about that is the absence of those figures point to the fact that the issue hasn't even been considered, and the issue of giving support to people hasn't been considered. So the absence of figures goes along with the absence of measures to address those figures. And any system is only going to work if we think very carefully about how we support people, whether it's people we ask to self-isolate, whether it's in situations like Leicester. If we ask for local lockdowns, we actually should be asking, how can we actually support people through those local situations? Not be punitive, not try and clamp down on them, but ask, how can we support? And unless we have the figures on isolate, we're never going to address that absolutely key question of how do we support people to do the right thing.
Just on that point, in China, every person who was identified as a contact or case was monitored and followed up for symptoms daily, as they were in Korea. We've got 25,000 people being employed on contact tracing who, as I understand it, have done no more than one each on average in the past month. Why can't they follow up contacts on a daily basis to check what they're doing and also to find out if they have symptoms or not, like they did in Asia?
Can I just add, in terms of the support, the two key things are accommodation, which again, I think in China and other countries was given, where people can't self-isolate successfully, i.e. they don't have their own kitchen, their own bathroom, which is actually true probably for most people in this country. They do need some place to isolate themselves, and not at expense to themselves. And the other issue is people who may lose earnings when they're asked to isolate for 2 weeks. If you think about human behavior and people are balancing up the pros and cons of it, if you're already struggling financially and you're looking at losing 2 weeks of wages, you may be much, much less likely to do it. So I think financial compensation and support in terms of alternative accommodation has got to be high on the list.
Thank you, Professor Mickey. Clearly a really important topic, and I'm going to ask that we move on because we have a huge number of questions to get through. I'm going to pass to Liz Hind, who's up next. Liz, are you with us? There we go.
Hi.
Hello.
So I'm a pub landlady, currently going through all the guidelines, risk assessment, staff handbooks, etc. Also with my own PhD in science communication, so following the guidance and the scientific advice from a number of different angles in quite a lot of detail. I mean, my question and my big concern at the moment is the guidelines that we've been given as pubs for how we need to set out our venues. So the guidelines state that, the social distancing is 2 meters or 1 meter with risk mitigation where 2 meters is not viable. What we're struggling to find is any sort of information that we can trust about what constitutes acceptable risk mitigation, if we're laying out tables, particularly inside. So you talk about ventilation. Does that, does leaving the door open and a window open count as having a ventilated space? So we've got all of these kind of really quite detailed questions about our particular situations and our particular units. And we're making it up as we go along, to be quite honest with it. There is nobody that I can ask these questions to. So I laid out my tables yesterday and sort of tried to measure them. And, obviously I can't move where all the walls are, but, who gets to say, actually, that's a good risk mitigation system that you've put in place there? And the answer is, well, we're all swapping information between different pubs, and there's a lot of rumour going around about what counts and what doesn't. And I am yet to be able to talk to an EHO about what they think about this, and it's actually a council employee that's coming to my pub tomorrow to have a look to see whether she thinks that I'm got something acceptable to open up on Sunday. We're opening up on Sunday and doing the sensible thing, because Saturday's a disaster, but that's a completely separate issue that we have with the government's advice on all of this.
Thank you, Liz. I think if I don't see a hand, maybe I'll go to Professor Pillai first on this one, and then I'll come to Professor Mickey.
Well, thanks, and I do support and applaud your the responsibility you're taking, and the fact that you're not opening tomorrow, which clearly is a worry for us all. Obviously, it's difficult in a sort of setting like this to come out with very specific recommendations, because it is about how it applies to each setting. And I think you're taking a very responsible attitude. And you're getting advice clearly tomorrow from the environmental health officer. And I'm pleased that is happening, although it is a bit of a shame that's not been more general guidance coming to you. I think the key thing before others will come in is to recognize an understanding of how the virus spreads. And I'm sure you're thinking widely about this. It is spread obviously through indoors. So indoors, a distance and masks are going to be an important component of that. Clearly, masks in the context of drinking and eating is difficult, and therefore one has to mitigate, have other forms of mitigation, particularly about how to place chairs and so on, and how to engage with customers. But please don't forget that drinking, saliva, touch, and so on remain a critical component of this, and therefore facilities, encouragement around hand washing facilities if at all possible, hand sanitizers if it's possible to have. I know there's advice about bar staff serving customers rather than customers bringing glasses back to the bar and recycling and so forth. So I think it's just basic principles and understanding about how the virus is spread, which will allow you to tailor that to your particular pub.
Thank you, Professor Pillai. Professor Mickey, can I invite you to comment on this one?
Just 3 practical tips, really, following from what I said previously. I think the more ventilation, the better. So just a general principle, the more circulating air you can get, the better. The more that people don't face directly opposite each other, the better. So the more you can have people at angles, the better. And also, I would ask everybody who comes in to the pub to sanitize their hands. Our local shop does that. It's actually a sanitizer on the outside of the shop, and everybody's asked to do it when they come in. And have hand sanitizers on tables or the bar or wherever, and keep on encouraging people to do that. I think the mask is a really difficult thing, because obviously that isn't practical. And one of the problems about a mask is if people are taking them on and off and touching them, if somebody is infected, they then can begin spreading around on surfaces. So I would concentrate on the other mitigating factors rather than trying masks in a pub.
Thank you, Professor Mickey, and thank you, Liz, for the question. I'd like to pass to Alexandra Thompson from Yahoo, if we could. Alexandra, are you with us? Yeah.
I think my video is loading. There we go. I'm sorry. I want to go back in time a bit to holidays. There's a lot of emphasis on staycations, but we know that hospital resources are allocated according to the permanent populations that they serve in terms of intensive care beds. And a friend of mine's a doctor in rural Wales, and she said there's 1 ventilator at the hospital. So is it responsible for people like myself who live in London to flock to these rural areas like Cornwall if they don't have the resources?
Professor Pargle, would you like to come in?
Yeah, I mean, if it's specifically getting COVID while you're away that you're worried about, I mean, well, I'm not saying it's a good thing about COVID, but typically for the first week, your symptoms are pretty mild. I mean, if you get symptoms. And so in that sense, if you did get sick while you're on holiday, you would have time to go home. I mean, I actually am thinking about it. I'm not sure there's been any official advice from the government about what to do if you get sick while you're away, because obviously you have to, the stay home doesn't apply, but you have to be as careful as possible not to contact or infect anyone else on your journey, which is something that actually just occurred to me. And I think that's really important that we give people that messaging. But in terms of, you're very unlikely to need a hospital admission before you have time to get back to your house.
Thank you, Professor Pargle.
Isn't this one where we should think economically? I mean, the hospital, hotel, letting businesses around the country have been absolutely decimated. The whole of their season has gone. Many people are facing bankruptcy. And the risks that you touch on, Alexandra, are actually really very small. And I think supporting our own holiday industry would be a great thing to do, personally.
Professor Scally, can I bring you in here?
Yes. Well, of course, places like Cornwall and other tourist destinations within Britain are well used to the summer surge of population and the problems that does produce in hospitals and for other healthcare facilities. So they are used to it to a certain extent. I agree with Professor Pargle. It's unlikely in terms of the duration of a holiday period that someone will get COVID-19 and then progress all the way to needing hospital care. It's possible, but it's unlikely. I think the worrying thing, and particularly the worrying thing for people in, for example, the southwest of England, which has significantly the lowest incidence of cases in the country, is that people, if you think at all that you're not well, you should not travel. It's quite simple, and people need to know more about the symptomatology. And one of the big concerns is that there may be low levels of understanding amongst the population what constitutes some of the symptoms for COVID-19. And that's one of the things the government should be doing now at the moment. We should be trying to educate the entire population to think again about COVID and learn about COVID, and have it in their minds that if they have any of these symptoms, not only should I not travel to other places, but I should isolate myself and I should seek a test. So I think holidaymakers going to other parts of the country have a responsibility to look after their own health. And the NHS, I'm quite sure, will be able to cope with whatever comes at them, because the NHS is well used to, in holiday destinations, of dealing with excess cases.
Thank you, Professor Scally. I'm going to pass to Professor Oni before we move on to the next question.
Thanks. I think just building on what Professor Scally just said about if you have symptoms, don't travel. I think it's also worth remembering all the different behaviors and interactions that can prevent and reduce the risk of transmission. So on your journey, what are the measures that you take and think about? So it's not just when I get on holiday, what do I do? So on my way there, what do I do? How do I think about those individual mitigating risk factors? Is it to do with the time of, if you need to catch a train, the time of day? Can you avoid the peak times, the hand hygiene, all the rest of that? But also what you do on holiday as well. So can you avoiding overcrowded spaces, using outdoors as much as possible? So all of those things come into play, and it's worth remembering the factors that we can actually control, and it's not just about waiting to see if you get symptoms or not, but actually reducing the risk of that as much as possible.
Thank you, Professor Oni. I'm conscious that we are over time, because there's, as ever, lots to say. I'm going to ask that we do 2 more questions, if that's okay. So I'm going to pass to Mark Knowles. Mark, are you with us?
I am. Hiya.
Hi, Mark.
Hi. Yeah, there have been a number of studies released in recent weeks regarding immunity, including antibodies detected as high as 42% in the ski resort in Austria that was badly hit. Also studies regarding possible assistance given from T cells and vitamin D. So what's the latest thinking regarding levels of immunity and percentages of the population that remain susceptible?
I wonder if I can pass this to Professor Pillai to start with, I think.
Thanks for a really difficult question. There's clearly a lot of work going on and research to understand what is the nature of the immune system, to what extent, if you develop antibodies, does that mean you're protected from infection? And as you quite rightly say, there are different bits of the immune system. There's antibodies, and there's also the T cells. And I think at this moment in time, there remains uncertainty about this. And therefore, we think that the idea of, for instance, being tested for antibodies and being told you're immune and get an immune passport is not, we're not there. That's premature. Having said that, there's no doubt that by measuring antibodies, as you quite rightly say, you can identify what are the groups of individuals who've been exposed highly. You mentioned 40% or so. I'm very well aware of data in hospitals, of those hospital workers that have been in close proximity to patients. And those are the figures that we're seeing. Something like 40% of individuals working in that environment have been exposed and have antibodies. What we don't know, though, is whether those antibodies will be protective against future infections. And secondly, the degree to which those antibodies may wane over time. And that's also another important point. Finally, this COVID-19 is part of a family of viruses called coronaviruses. So we know a fair bit about the immunity to those viruses. The coronaviruses that are not like COVID-19, they cause mild respiratory infections, cold-like symptoms, and we know that people can get those infections each year. So protection is not clear. So that's that. Unfortunately, there's still a lot of uncertainty about this, and I just reaffirm that it's premature to be using antibody tests to say anything about you as an individual being protected in future.
Thank you, Professor Pillai. I wonder if I could pass to Professor Kunti, who has some specific thoughts around vitamin D.
Thank you, Zach. This question has come up quite regularly regarding vitamin D, and there's been a couple of reviews that have been done recently. Basically, there isn't any good quality evidence to tell us whether vitamin D is protective against coronavirus. There's been a number of publications, and this is where we get the hype that people who've been admitted, they have low vitamin D, but these are often biased results because people who are from deprived areas, they're more likely to be admitted and they're more likely to be vitamin D deficient. So we do not know for sure. The guidance has come out that we should all be taking vitamin D, and that should be the case. That's an easy thing to do using something you can buy over the counter because about 80% of people have vitamin D anyway. To get the good quality results, what we would need is randomized control trials. There's only one that's been done in respiratory diseases in a hospital setting, which did show it protected people, but not for COVID itself.
Thank you, Professor Kunti.
But there is a trial ongoing at the moment.
Thanks. I'd like to invite Charlotte Carter from Select Science to ask the last question. Charlotte, are you with us?
Yes, hello, thank you. So at risk of repeating what's already been said, how likely is a second wave with lockdowns and shielding lifting and with cold season approaching? But also, are our services, so our hospitals and clinics and labs, are they equipped to deal with such a wave in terms of PPE, manpower, and also testing resources and resources for coronavirus research?
I'm looking for a hand, otherwise perhaps Professor Pargle. Let's go to Professor Pargle.
So I can't talk specifically about labs and things, but I am actually quite concerned that the government seems to be kind of hoping for the best without planning for the worst. And I'm worried that they're not spending this time making plans for what happens if there's a second surge, whether that's PPE testing, things like people with kidney problems, but even things like how do we do much better on schools if there's a second wave? What do we do about that? How do we support people with businesses? I mean, all of these issues, I'm just worried that there's not a plan for.
Thank you. Professor Friston and then Professor Pollock, if that's okay.
So from the modelling perspective, I think it's fair to say that the second wave, should it encroach upon us, will be of much lesser magnitude than the first wave. So, I mean, this is a bold statement and it has to be qualified with all the usual qualifications, but you can anticipate an order of magnitude less fatality and implicitly morbidity with the second wave. So I don't think the question is, can we cope with a second wave? I'm sure that we will cope with it, even to the extent I can guess it probably won't even make headline news. I think the bigger question here is there's an opportunity to save the lives that will be lost in the second wave. And that seems to be a much more pressing question. And the way that you can only do that is to accelerate the FTTIS system. So if it is the case, as Dean was sketching, that the kinds of effective immunity that preclude or will enable these long-term dynamics to release a second wave in early January, if that second wave does occur, then we can suppress it with a reasonably efficient FTTT sort of testing and tracking isolation support. So I think that's what the question should be. Do we want to save lives by trying to suppress the virus in this window of opportunity? I wouldn't worry so much about could the NHS cope.
Thank you. Professor Pollock, would you like to add to this?
Well, I think it's important to note that as well as COVID deaths, we've had excess deaths from non-COVID. And that's partly because we've been really a COVID-only emergency service. So many people with cancers, cardiac strokes have not had the treatments that they need. And there's an enormous backlog, especially for elective surgery. So it's essential that there's really good planning so that we don't return to that situation. And that's why it's really important that we have an effective test and track and trace system, and that it's local, that we expand the NHS laboratories, we expand the public health locally and the contact tracing teams. And the other factor that we haven't considered is primary care. COVID so far has been really bypassing primary care and GPs, but come the autumn, COVID symptoms are going to be very like flu symptoms and all the other respiratory tract infections. So it's really important that primary care is brought back in to the system, and that they, through NHS 1:1 and GPs, telephone triage, are actually ensuring that the ordering of tests is happening, the clinical management of patients is happening, and the support of patients, cases and contacts in the community. Susan already talked about the importance of the financial support, but we don't have any community health monitoring going on. And in many countries, what's happening is that monitoring kits are going into the homes to look at temperature and oxygen saturation meters. And actually there's daily monitoring of people and how they are. Now that needs to be done by healthcare professionals, not the contact tracers who've been recruited as sales advisors. You need people that the cases and contacts can trust, who are really trained up. So what I'm coming around to is we really need a plan for action that covers not just the hospitals, but public health, contact tracing, the testing system, and primary care, and that it's integrated and seamless and working. And that's a huge challenge that we have. We've already lost a lot of time over this last 4 months. We still don't have the effective contact tracing system, and that needs to really be a priority.
Thank you, Professor Pollock. I'd like to invite some final comments from Professor Riker and then Professor Oni, and then we'll wrap up. Thank you.
Whether we call it a second wave or increases in infections is, of course, critically dependent upon behaviour and upon compliance. And I really don't think we're doing enough in order to address those questions. And there are three key factors if you want people to comply. The first is to ask about how we can rebuild trust and a sense of equity, so that everybody does feel as a community involved in what's going on. We're seeing increasing sections of the population who feel that there is an inequity and who are beginning to be alienated from the government and its measures, not least young people, because while young people might not be affected by the virus, young people are most likely to be affected by what comes next, by the recession. And if young people begin to feel that there is no future, they are much less likely to take measures to look after their health and after public health. So the first issue, I think, is very much about equity and trust. Second issue is information. I mean, one of the things that has come through today is the number of areas where there isn't basic information. What I thought one of the most shocking things in Christina's introduction was the fact that the websites on the whole don't even tell you to get tested. And most people don't know what the symptoms are. So we need a massive campaign of public information, something you can't avoid, something that's in every bus stop, something that's on every time you open your social media. We really need that information because people don't have it. And the third thing, and again, it's been mentioned, is the support so people can do the right things. No good telling people to do things if it's impractical or impossible for them to do it. So I think those three pillars, the pillar of trust, the pillar of information, and the pillar of support, are necessary to get the compliance to make a second wave less likely.
Thank you. And Professor Oni, some final comments, if you could.
Yes, just picking up on the point of equity. And the question was, could we cope with the second wave, etc. I think there is another question of challenging the inevitability of some of those of future surge, and reflecting on the things that we already know. So picking up that equity dimension, we already know about the differential vulnerability in people with comorbidities, in Black minority ethnic groups. And so what are we doing in terms of the planning? How are we putting plans and systems in place addressing that differential vulnerability? We already know that there's some differential exposure, thinking about key workers, thinking about people in the gig economy. Again, how much of the planning and the systems preparing for that speak directly to that? And lastly, as Professor Pollock mentioned, differential access to care, access to information. We know some of those barriers, what Professor Riker just mentioned. How are we consciously and deliberately addressing those different dimensions of equity, the vulnerability, exposure, and access that we already know? Because there's no good knowing it if then we're designing systems as if that are neutral, that are not responsive to those nuances. So I think it's just to highlight that in thinking about and preparing for a second wave, tailoring any plans to the dimensions of inequity that we already aware of is an important strategy.
Thank you, Professor Oni. And thank you to the whole panel. It falls on me to thank the Independent Sage Group as ever for these timely and weekly events that we're now holding. And also thank you to the public, for those who are watching on Twitter and YouTube, and all of you who've submitted questions. We'll be inviting the same next week, so we look forward to seeing you then. Thank you.